for us to make sure that they have blood flow. If you can't find the blood flow, I need for you to put on power color. And if they don't light up with power color, then you know you've got a problem. Of course, you're going to try to change your window in several different localities of the liver to try to get the hepatic veins to show up.
Mm-hmm.
If you have thrombus in the hepatic veins and you have thrombus going into the IVC, you'll see it at the IVC and the right atrium right before it dumps in. Now, I know that you're seniors now, so you're out of the protocol, and now you need to start looking for any type of disease processes.
Yes, ma'am.
Because there's a reason why we teach you to do that IVC shot. Remember, it's aorta, caudate lobe, and then IVC.
Yeah.
So you have to follow the IVC all the way up to where it empties out into the heart, so that way you can rule out Budd-Chiari. Good morning, Sophie. So when you have Budd-Chiari, you'll have a triad of 3 different things. You'll have ascites, hepatomegaly, and abdominal pain. So generally, you're going to have occlusion for at least two hepatic veins for it to be clinically significant, because the patient won't show too many symptoms with just one hepatic vein that is going to be obstructed. It is on the registry, so make sure you know who it is. Budd-Chiari, it comes about from birth control pills, tumor invasion from hepatocellular carcinoma, renal or adrenal carcinoma, especially renal cell carcinoma. It will invade the IVC. Any type of metastatic disease to the liver. Wilms tumor in the pediatrics, that's also known as a nephroblastoma. If you see renal cell carcinoma in the pediatric region.
Ms. Sheffer,
if you've had radiation to the liver. Okay, if you've had radiation to the liver, it's going to make the liver very fibrotic and hard, and so your hepatic veins are going to be hard to see, and that's when power color comes in handy for you. Okay. So other findings with Budd-Chiari are going to be portal hypertension, and there's 2 things that you need to criteria that you have to have for portal hypertension. It could be hepatopedal flow still, so you can't use that. But if you have a hepatofugal flow, for sure, you're going to have portal hypertension. The main portal vein has to measure greater than 1.3, and then if it measures greater than 1.3, you're pretty close to having hepatofugal flow. But as far as sonography, anything over a 1.3 is our definitive measurement for portal hypertension. So if it measures 1.3 and the liver is a normal size, then I need for you to take measurement again on expiration, because you don't want to give the patient portal hypertension if they don't have it. Sometimes if you go more into the liver to take your measurement, instead of staying at the liver hilum, the measurement can be lower also. If you have intrahepatic collaterals, then that's a sign of portal hypertension. Ascites, splenomegaly, and if you have a flow disturbance of the IVC should be blue at all times. But if you have flow that is red and blue and green and orange, then you have a flow disturbance in the IVC. So you need to make sure that you're looking for some type of a thrombus. You can also do a Doppler signal. The hepatic veins will have a very pulsatile flow where it looks like a W. It won't be arterial flow, but it will mimic arterial flow in the IVC and the hepatic veins because you're so close to the right atrium of the heart. Your portal vein should always be monophasic. It will usually always be above the baseline, but if it is not, then we need to find out where the level of obstruction is going to be. So you're going to look at the portal vein, make sure it's all one color, that it's not mosaic, the hepatic veins, and then again the IVC. So you can have passive liver congestion. That's when you have large volumes of blood exiting the liver. The hepatic veins with the IVC as it enters into the right side of the heart. If the patient is in, congestive heart failure, then, or if they have pulmonary disorders, that can cause a dilatation of the hepatic veins and the IVC. You always want to do a Doppler signal of the hepatic veins and of the IVC if the IVC is dilated or the hepatic veins are dilated. So here they call this the Canadian moose sign, and you can see how dilated the right hepatic vein is, the middle hepatic vein, and the left hepatic vein.
Is that dilation the same as portal hypertension?
No.
I'm sorry, this IVC.
It's not portal hypertension. This is due to congestive heart failure.
Mm-hmm.
Or if the patient has COPD. If the patient has COPD, it will also, blood backs up in the heart because it can't go through the lungs like it's supposed to. So it's also going to back up the IVC and the hepatic veins. Because remember, the blood from the IVC goes into the right atrium, goes into the right ventricle. So if the patient has tricuspid valve regurgitation, it's going to back up the IVC. If they have COPD, the blood can't go into the lungs through the pulmonary arteries, and then that's going to back up the IVC and the hepatic veins. And this is what it's going to look like if they're in congestive heart failure. It looks like it has a W, and it will be, normally you're going to see it above and below the baseline. This is of the IVC, and V is of the portal vein. Budd-Chiari. Budd-Chiari is an obstruction of the hepatic vein. The outflow may or may not involve the IVC. It can be congenital. They can be born like that. There's obstructing membranes on the IVC that they can't see, and you'll have polysthenia vera. Does anybody know what that is? Polysthenia vera.
I'm not sure about that.
Something too much.
Yeah. Too many white blood cells, maybe?
Yes.
Yes. Too many. I can't remember either. Okay, so let's go through the hepatic cyst. We kind of flew through this yesterday. You can have true hepatic cyst, or you can have acquired hepatic cyst. Congenital are related to polycystic liver disease. They can develop through intrahepatic bile ductules. They can increase with age. They can, if they're acquired, it can come from trauma, parasites, or any type of an inflammatory condition. Congenital cyst also, not only is it polycystic liver disease, it could be affiliated with autosomal dominant polycystic kidney disease. The right lobe is usually going to be affected more than the left lobe. They can be tiny, but they can occupy large areas. They can cause the liver to increase in size. You can have palpable nodules when you go to your doctor. They do cause abdominal discomfort. They can compress the bile ducts, and if that happens, then you can have elevated LFTs. Congenital cysts, they can go in and do a biopsy on those. That is usually done in interventional radiology. The fluid is usually going to be straw colored because of the bile. Contrast enhanced ultrasound, they can inject contrast microbubbles into the system, and that can help differentiate between a complicated cyst or a malignant process. There's two different kinds. You can have polycystic liver disease, or you can have autosomal dominant PKD. And you abbreviate that ADPK. Oh, my brain just went blank. Autosomal dominant PKD. ADPKD. So here's a congenital cyst. The patient is asymptomatic. It has the three criteria for a simple cyst: clear defined borders, anechoic, posterior enhancement. And you can see there's one anterior liver and there's one posterior liver. This is reverberation. So the only way that we can get rid of reverberation is to change our window or to use our TGC. Well, it will go further. Okay, so here you have congenital cyst, and you can see that it's taking away most of the parenchyma of the liver. So we cannot tell the difference between PLD and autosomal dominant polycystic kidneys that go into the liver. As far as we can know, the only diagnosis that we can give as sonographers is polycystic liver nodules. Here again, you have polycystic liver disease, polycystic kidney disease, and you can see that the pancreas is here. So sometimes they will, if you look at the spleen, you'll see polycystic cyst in the spleen as well. Acquired cysts are a hematoma from trauma. or from an invasive procedure. A bilioma, which is a tumor, a cyst that's full of bile. Parasitic, which is a gonococcal, or an abscess, which they will have an inflammatory condition and it will be a heterogeneous mass. An acquired cyst can be from, like we said, an interventional procedure, hepatic artery aneurysm, or pregnancy-induced hypertension. Symptomatically, the liver will be very tender. The patient could go into shock. Shock is a decrease in blood pressure, a decrease in your pulse rate, and your hematocrit levels will drop. If it is severe, the patient can actually pass away from the blood loss. We can see contusions, whether they're subcapsular, whether we have a laceration, or whether we have a rupture of Glissen's capsule. If we see hematoperitoneum, then that is urgent, because they will have to take that patient straight to surgery to be able to stop the bleed. Sonographic appearance. It depends on the age of the bleed. If you have an early bleed, it will be isoechoic to the liver. As blood gets older, it will become more hyperechoic. And then as the cells get older, they can build up septations and eventually turn back to hypoechoic.
You mean hyperechoic? I mean anechoic?
You'll get iso, hyper, hypo.
Oh, okay.
Okay? So septations are usually as the red blood cells are decaying. They can build up septations, and then that's why it looks like we have a honeycomb or a spider's web, because eventually the spider web will be hyperechoic to the anechoic structure. Does that make sense?
Yes, ma'am.
Okay. So Hepatic disease comes from a tapeworm. And what happens is the tapeworm comes from eating food that is not clean. And what happens is it travels up the portal system and gets into your intestines, and then it travel up to the portal system by way of the superior mesenteric vein and the inferior mesenteric vein that join the splenic vein that goes into the liver. Okay, so what happens is that cyst can develop daughter cysts because the larvae keep multiplying. And so what we look for is a cyst within a daughter cyst, and you can sometimes see debris. The older that cyst gets, it can calcify, and you can actually see the tapeworm moving with real time inside of the liver. They're wicked looking. So here's an acquired cyst. A is a fresh biopsy, and B is 4 hours post biopsy. So you can see that the fresh in A is isoechoic to the liver parenchyma, but then 4 hours later, it's already turned anechoic. This is Glissen's capsule that we see here. So Glissen's capsule is the capsule that surrounds the liver. Okay, so here we have 2 lesions inside of the liver. Why is this doing this? 2 lesions inside of the liver, and upon needle biopsy, it was a bilioma.
Bilioma.
And a bilioma is a lesion that is full of bile.
Oh, bile lesion.
Okay. Here is a conococcal cyst, a cyst within a cyst. We call those daughter cysts. And here it is a conococcal cyst that has turned isoechoic with a calcified rim around it.
Ms. Shepherd,
Yes.
the image D, if we were to measure that, and we do measure this, correct?
Yes, and put color on it.
Can you show us with your cursor where we would measure?
Okay. So it looks like it's pretty round. So I would measure from here to here because I'm going to include the wall. And I'm going to include from here to here because I can see that. I can't measure it from here because this is an artifact. So I'm going to measure it where I can see it. So it would be from here to here. Be sure you include the wall.
What about image D?
Image D, we would have to measure it from here to here. You can give it individual measurements, and you're going to start with the biggest one. And you're going to go A, B, C, because you want to label those individually for the next sonographer that comes behind you. So you can start, and it's your choice. You're going to develop your own system. But I would usually start with the bigger one. I would measure the whole one as a whole, and I can only measure what I can see. I would measure it from here to here and from here to here. So you can see that it's taking up most of. This could be a pleural effusion. I don't know until you're looking at it. And then you can measure each one individually, but be sure you number them. I would wait until I finish the liver, and then I would dual screen it. This would be 1, this would be 2, this would be 3, and I would only measure the top 3 ones. Okay, does that make sense?
It does. Thank you.
Okay. I wouldn't take the time to measure each one of those. I'm only going to follow up with the top 3 big ones. These we went through. So let's talk about pyogenic abscesses. What does this word tell you? Just pyogenic. It's full of pus. So we know that it's going to be heterogeneous. Hepatic abscesses can be bacterial or parasitic. Anytime we see something in the liver, we're going to locate it, we're going to measure it, we're going to describe it, and we're going to put color on it. The patient will have pain, fever, elevated white blood cell count, which is called leukocytosis, and we can guide the radiologist into aspiration of those liver cysts or the liver abscesses. Now, I just thought of something that I don't know the answer to. I don't know if they can put a drain in a liver abscess like they can if it's in the abdominal cavity. because they wouldn't want any more bacteria to go into the liver. That might be a question for research, because I have no idea about that. I know when they do an abscess of the breast, they can put in a drain. If they do an abscess in the abdominal cavity, they can put a drain. But I don't know if they would do that for the liver. A pyogenic abscess can also come from E. coli. E. coli is, we can get that from food. A few years back, my girlfriend ate some cantaloupe. Oh, that was listeria. Never mind. So those are two different times. So listeria is also a very bad disease that we can get from unwashed food. Or what happens is if they fertilize the ground with feces that is contaminated, like you have raccoons and beavers and all kinds of things that come in to our crops, and they can't get all of that off. So they develop from the reticuloendothelial system and can develop severe sepsis. Now, the reticuloendothelial system is the spleen. The spleen has phagocytic cells, but so does the liver. The name of those cells in the liver are called Kupffer cells, because they are the phagocytic cells of our liver that try to eat up all of the things that shouldn't be belong into our system. So what happens is if those Kupffer cells don't get all of the organisms out, then they can end up in the biliary tract. And if the biliary tract starts proliferating the bacteria, then you can also develop several abscesses in our biliary tree. And so it's some bad stuff. These people are usually going to be in the ICU. So we won't examine them unless they come through the emergency room or unless we do ICU portable patients. There again, the bacteria enters through the portal system by the hepatic artery, or what are the two vessels that feed into the portal vein?
The superior
Superior and inferior mesenteric.
Very good. The mesenteric veins, not the arteries. Because remember, the arteries come off of that aorta, and one feeds the right side and one feeds the left side. It's the veins that go back into the liver. So if I have a pyogenic abscess, I can have a fever, leukocytosis, elevated LFTs, right upper quadrant pain when I breathe, and hepatomegaly. Okay, we're mostly going to see them in the right side, but they can be several shapes. They could be round, ovoid, or poorly defined, like what we saw earlier. They can have internal echoes with debris, adhesions, or gas microbubbles. If I have gas microbubbles, let me see, where's that image? Oh, gas microbubbles right here. That is a severe condition because once gas gets into the system, it has a very high mortality rate. What is she doing? Piper. Okay, so the differential diagnosis of a hepatic abscess is going to be, of course, a cyst. It would be a complex cyst. It wouldn't look like a simple cyst, right? A hematoma, a bilioma, a necrotic tumor, a conococcal cyst, or a metastatic cystadenoma carcinoma. Here is a pyogenic abscess. Here you can see that it's very defined. We do have posterior enhancement behind it from here to here. You can see that we have posterior enhancement. So we can see that a lot of the mass is going to be fluid filled. And here we have a very large abscess with the patient with cholecystitis.
Cholecystitis is the wall gallbladder inflammation.
Yeah, cholecystitis. No, Piper. Leave it that alone. Okay, so this patient presented with pain, fever, and a history of diverticulitis. Do y'all remember what diverticulitis is?
Yes. Outpouching. Was it outpouching of the colon?
Yeah, it's an outpouching of the colon. It looks like, and the patient has to be very aware of what they eat because strawberry seeds can get stuck in there. And the regular one is called diverticulosis, but if it gets inflamed, it's called diverticulitis. So they couldn't see any color on here, so of course they're using angio color or Fowler color. And here you can see that there is gas inside of the biliary system. So this is going to be a very traumatic case. So an amoeba abscess, you get it from a parasite, from contaminated food or water, and our blood can carry the parasite up through the portal system from the mesenteric veins. As long as the parasite stays in the GI system, we'll do so normally try to pass that out. But if the parasite travels up into our liver, then we're going to develop right upper quadrant pain, hepatomegaly, diarrhea, fever, chills, jaundice, and black tarry stools. You'll have leukocytosis because the body is trying to fight off the disease process. You'll have mild anemia because you're bleeding into your stools, and that's what causes the black tarry stools. We can have elevated LFTs. The more mature masses are going to contain fewer echoes. They're going to develop smoother walls. They're going to have distal acoustic enhancement, and sometimes you'll have calcifications that develop with those. Of course, it's the right lobe that's going to be more than the left lobe. So here you have a parasitic infection. So you can see that it is anechoic. It does have posterior enhancement that we can see over here. Here it's up against the wall, so we can't see it. And you can see that the patient has a pleural effusion. So here, the red blood cells you have broken down, and you have secretions. You have an irregular wall. So all we can do is call that a hypoechoic complex mass.
How do you differentiate the pleural effusion from just regular lung tissue?
Okay, regular lung tissue we don't see. But see this little V right here? That's our sonographic sign for pleural fluid.
Okay. Not the black area?
You have to have one of these before you graduate.
Okay.
Okay, so anytime, and when you're going to see this is when you're looking at the liver and the right kidney, because you're going to see the liver and then you're going to see this little V, and that's our sonographic sign for pleural fluid. You should never have fluid inside the pleural space.
So do we need?
Normally we don't see lung,
Okay.
but we can see lung if it has fluid in it.
So Miss Sheffer, do we need to measure it in sagittal and transverse?
There's no way to measure it in sagittal, Dewey, and so you'll just measure it from here to here.
Okay.
From where you see it, and we stop seeing it here because of the field of view, and then you're going to measure it from here to here.
Okay.
You can't measure it this way because it's to infinity, so
Yes,
you
ma'am.
only measure it in one plane.
But however, that is done on the sagittal view of the midclavicular livers.
No, you don't always see it there.
Okay.
You don't always see it there. When you're coronal, you're going to see it the most. When you're looking at your long kidney, slide up, and then you're going to see it here.
I saw it's one, but I don't know what it look like. So Mr. JT say I can relabel and do it. I know, but I didn't know.
Yeah, you can only measure it in one plane. Yeah, you can have a pleural effusion on the left or on the right. It will still have the same sonographic sign.
So, Ms. Shepherd, the only way to differentiate between pleural effusion and ascites is the sonographic sign?
Exactly, because a pleural effusion will look like a V, like what you see here. Ascites, you're going to see it up here, or you're going to see it right here. You're going to see it in Morrison's pouch. A pleural effusion, you're not going to see in Morrison's pouch.
Is that possible for patient have both, like ascites and pleural?
Yes, sometimes you can have ascites with a pleural effusion.
Ooh, that's up.
And that's what you're going to see most of the time. Ascites with a pleural effusion. So you have to know the differences between the two. A pleural effusion is in the chest cavity. Ascites is in the peritoneal cavity. I'll try to pull up some images. Let me put that on my list where I have a pleural effusion with ascites for the seniors. Okay, I put it on my list. Did we do these yesterday?
Yes, ma'am.
No, did we? I can't remember.
Okay, so Shasta's HIV. We kind of went through this a little bit yesterday too, right?
Yeah.
Yes.
Okay, Shastomyosis is a parasite. It penetrates the skin. You can get it even walking on infected dirt, and it can travel up your lymphatics and get into your bloodstream, and then travel through to the liver through the mesenteric veins. So it can even get as far as the urinary bladder. It can cause fibrosis of the liver. It can even develop into cirrhosis. Clinically, you're going to have portal hypertension, splenomegaly, gastroesophageal varices. You're going to throw up blood, hematoemesis, and you'll have ascites. So depending upon how long you've had the disease process, will develop what happens to the liver. And of course, if you're in liver failure, if your liver's not If your liver is not functioning as well as it should, if it gets too fibrotic, then you're going to get splenomegaly because the portal vein can't feed the bladder, the liver like it should. If that happens, God's going to open up, he's going to develop varices. And then once the varices can't hold any more blood, then God's going to open up collaterals so that way the organs can continue to get the blood that they need.